moving on to this segment, I kind of want to go a little deeper into the files that contain MA data, particularly the RIF files that contain encounter records, which are kind of like the MA version of fee-for-service claims, like Steph kind of explained in segment 2, I think it was. So I'll list the CMS files that contain MA data. I'll talk about file structure for some of the files, their content, and do some comparisons with the fee-for-service RIF files, or RIFs. Okay, so our counter data are available in RIF format only. So, maybe that doesn't make sense to you, but there are no limited data or public use versions like there are for fee-for-service. So for fee-for-service, there are less versions of the RIFs that have less sensitive information, but they are not available for the encounter data. So RIFs contain personal health information, or PHI, and while most RIFs don't actually contain direct identifiers like social security number or name, there is enough information that when used in combination, a person could potentially be identified. So, for example, if you combine zip code with date of birth and date of death and service dates, you might be able to identify an individual. So, in order to protect members' information, researchers must sign a data use agreement in order to use these data. So that's part of the process of getting access to these data, is being willing to sign a DUA. So researchers can customize the individuals included in their data when they're constructing a research project, and they can tailor a cohort based on criteria such as geography, diagnosis, procedure, service, or a researcher can even submit identifiers like social security numbers if they have a list, and then the CCW, I believe, will identify those members for them using those identifiers. So it is possible that these data can also be linked to external data sources if a personal identifier is available. So that's also an option. CMS charges a fee for these data, and that fee varies depending on a few different factors. So it depends on how many files you're requesting and years of files you're requesting, cohort size, and the access method. And so if you have more questions about cost information or anything else, please visit our website, ResDAC.org. There's a lot of great information that'll kind of get you started on that road to understanding what it takes to get access to the data. And you can also send questions to ResDAC assistance desk, which is just ResDAC. I forget what is our email address. Well, we'll put it in the chat later, or maybe Steph will, but it's free to use the ResDAC assistance desk. So feel free to send us questions. All RIF requests require a research backbone. So there must be a clearly defined study with specific aims and objectives. And ResDAC can help you with that, defining your research project so that it's acceptable and meets the requirements of CMS for approval. CMS Privacy Board review is also required. And so just so that you're aware, and all the request process can take around 4 to 5 months. So it's not, just to give you, set your expectations on the process. It does take several months. So, the RIFs come as annual files only. And, so compared to fee-for-service, there is more lag time in when they become available, the encounter files become available. Because MAOs typically have up to 13 months after the end of year to submit encounter data to CMS. And so like a preliminary, the preliminary 2022 encounter RIF was released in May of this year to give you kind of an idea of the lag. So this chart depicts an overview of CMS research data files that contain Medicare Advantage enrollees. Like we talked about in the previous segment, the MBSF contains all Medicare enrollees, including Medicare Advantage members. There is the same set of encounter files as fee-for-service when we're talking about service records, with the exception of hospice. The hospice data is found in the fee-for-service hospice file, and that is because the hospice benefit is carved out of Medicare Advantage. There's a file called the MedPAR file, if you're familiar with the MedPAR, that contains inpatient and skilled nursing facility data. And that includes stays for Medicare Advantage members as well as fee-for-service. However, the records in the MedPAR for MA are not comprehensive, and they do lack some of the detail that fee-for-service stays contain. Part D files contain both fee-for-service and Medicare Advantage Part D events, as do the assessment files listed on this chart. And the like I talked about in the last segment, the plan characteristics file contains detail on MA plans. So when we're talking about linking Medicare Advantage files together, the same approach as is done for the fee-for-service files applies to the encounter files. So where the Benny ID is common among all of the files. So the same member will have the same Benny ID in file X and file Z, and you know, it will be consistent across all files. And so, you know, that is just a very key variable when you're gathering, say, all of the records associated with a particular Benny's surgery. You know, you'll have to look in the inpatient file, and then you might want to look in the cure file to gather the physician bills for that stay. You'll need the Benny ID. So knowing which type of members are included in each file is just something to keep in mind when you're evaluating utilization and outcomes, because you don't want to double count unknowingly. Many CMS files are limited to fee-for-service or MA, but a few files contain both. This is a good visualization, kind of showing you that all the files listed in the far right of the tree contain both fee-for-service and Medicare Advantage beneficiaries. I've already kind of touched on that already, so I'll keep moving on here. So now I'll just kind of go more into detail on the encounter RIFs, starting with the institutional files. You know, kind of as a logical way to sort of separate the files into institutional versus non-institutional, because it relates to the claim forms used to submit institutional claims versus non-institutional claims, or different claim forms used. And so that kind of has implications for how the data files are structured and the variables included. So anyway, I'll just start off talking about taking a look at the institutional encounter files. So institutional files include inpatient, outpatient, home health, and skilled nursing. This is the same as fee-for-service, except for hospice, which we already talked about. So for all of the encounter RIFs, there's going to be a base file and a revenue center file for the institutional RIFs. So in other terms, a header and a trailer file. Well, the base will be one record per encounter. The revenue center file might contain multiple lines for that encounter, and you link them together by using these three variables. That will give you the unique key that you can use to link the base to the revenue center file. And again, just a shout out to the CCW Encounter documentation. There's a user guide that will explain all this in great detail, and highly recommend kind of reviewing that critical guide before starting on a research project. Really help.
Can you just say quickly why they're linked by encounter join key rather than Benny ID?
But you use all three of these variables up here to link. So you need all, yeah, and that's according to the user guide. So yeah, need all three according to the user guide. Okay. So I just want to point out quickly that there are also, besides the base and the revenue center file, there's also 4 lesser used reference files available. There's a file called the condition file, the occurrence codes, span codes, and value codes files. And there's kind of a description of what they might contain in the table here in the slide. They're not used nearly as often as the base and revenue center files, but just so you're aware, they're out there. And if you want to look into them, and you join the base to these files using the same 3 variables as to the revenue center file. So the base segment contains a summary record for each encounter, and also has the Benny ID. All files have the Benny ID. Claim dates, facility type in the form of MPIs only, unfortunately no CCN, DRG codes and derived DRG, that's for the inpatient file, and also 25 diagnosis codes and 13 procedure codes. So the content is very similar to fee-for-service files. Again, there is unfortunately no CCN, but and we are not aware of we don't believe there is a comprehensive CCN to NPI crosswalk available. However, we will kind of talk in the afternoon about kind of a way to categorize NPIs in a useful manner using the NPES file, which stands for National Plan and Provider Enumeration System file. Also note that DRGs are not as well populated in encounter data as fee-for-service. And that's because of differences in billing policies and payment structures by Medicare Advantage organizations. So that means that some of them don't use a DRG for those services. And so this variation in how plans handle their billing may contribute to MAOs populating some variables less consistently than fee-for-service claims data. For example, an encounter data is far more likely to contain a DRG of 000 relative to fee-for-service data. But luckily, CMS has created a derived DRG variable that's available in the inpatient file. So that's where this kind of 3M software has created a derived DRG that could be helpful to fill in those kind of missing values. One final note on the derived DRGs. Investigators should not use this variable for records for inpatient rehab facilities or chart reviews. For some reason, it must not really work for those records. Okay, so moving on to the trailer file or revenue center file, there is one line per revenue center. And so there might be multiple revenue centers per encounter. So you're going to have a one-to-many join when you're joining it to the base file. You know, the content is similar to fee-for-service, but different in that there are no financial data fields that, like Steph already talked about in the earlier segment, because that data is considered proprietary by Medicare Advantage organizations, so they don't want to share it. I think one thing that the encounter files have that fee-for-service files do not are line from and through dates. So that's a little more added detail. That's nice. But just like fee-for-service files, it contains HCPCS codes when applicable. You can see the encounter records code book for a complete list of variables. So here's a quick poll question. I don't know if Steph will actually have it officially go out to you all to answer, but here's the question. Where do you find demographic information for members of a managed care plan? Yes. I think you're all listening well, because the answer is the MBSF file would be the go-to source for demographic information, and 97% of you selected MBSF, so good job. I think, as I mentioned earlier, the counter data files might have a few demographic variables, but I'll let Steph do that. I think I may have shared the results, I'm not sure. But we recommend using the MBSF for demographic information. So here's kind of our first or another comparison of fee-for-service to encounter utilizers in the institutional records. We kind of want to just see what they look like. How do they compare fee-for-service to Medicare Advantage? And so here we tally the percent of beneficiaries that had any claim or encounter by file. So for the fee-for-service population, almost 14.9% had at least one inpatient record, where compared to Medicare Advantage, the percentage is 13.5%. So kind of in the same ballpark, a little lower for Medicare Advantage. And you can see how the same metric compares in the outpatient, skilled nursing, and home health files, kind of similar in the same ballpark, but Medicare Advantage is a little lower in each category. So how do the files compare in overall number of records per patient, and how many revenue center lines are there per claim? That's what we're kind of comparing in this set of charts. So, and just one note, the medians that we're presenting here do not include chart reviews. So this data is from 2021. And you can see that the median number of claims per patient in the inpatient file was one. And that's for utilizers, those who had at least one claim. The median is exactly one claim for inpatient, 4 claims for outpatient for fee for service versus only 3 for encounter, etc. So there's a little bit of difference between the two populations, but pretty similar. And then when we compare the median number of revenue center lines per claim record, comparing fee for service and encounter, it's again quite similar, with the exception of home health. Home health has more lines in the fee for service data, and this could be driven by differences in billing policies. Fee for service required episodes, like home health episodes, be billed on a 60-day basis up until 2021. And then it changed to a 30-day basis, but Medicare Advantage organizations may have totally different billing requirements for their home health providers. So, that is probably driving this big difference that we see in that second chart there. So it's just something to be aware of if you're working with home health data. That's just something to be aware of, and you might want to really get a good feel for the home health records you're working with, and make sure you're understanding what's going on before you make assumptions, and how you decide how to do your analytic work. There is also some question as to the completeness of encounter home health data. We have not looked into this, but again, keep these things in mind. We also looked at the number of diagnoses on claims and encounter records, and there's very similar number for the two categories. In this chart, I've also included chart reviews, where the previous charts they were excluded, but here I've kind of included them separately because they pertain specifically to diagnosis codes. So kind of interesting to see how many the median, what the median is. They're intended just to add or delete diagnoses. They're not intended to completely replicate previously submitted records. So that's why the median is much lower compared to service records. But you can see that it's pretty similar from fee for service and encounter when it comes to service records, with the exception, of home health. That could be because of the sort of billing scheme differences again. Also just kind of wanting to get maybe like another sort of measure of similarity is we had the idea to sort of look at emergency department bills and see are there's kind of like similar volume of emergency department records, when we look in the inpatient file and the outpatient file, and there's like similar coding kind of patterns. So here we identified all records with an ED specific revenue center code or HCPC code, and for both fee for service and encounter, the vast majority had an ED revenue center code. Very, very few records only had a HCPC code. So it just seems like there's a lot of similarity in what you can expect in the billing patterns. But you can't assume that. It's still something that you might, you need to kind of get to know your files and your data before moving ahead and making assumptions. But it is looking pretty similar for emergency records between the two groups. There are some key differences between institutional, encounter, and fee for service records, like Steph introduced you to already, and I've talked about a little bit. There's a potential for multiple records for Encounter in the form of chart reviews. There may be a very small number of multiple service records for the same service, but it should be a pretty small number. Depends on how you define duplicates. And I'll talk about that a little bit more in a few slides coming up. One of the biggest differences is that there is no payment data in the Encounter files, unfortunately. But Peter this afternoon will kind of talk you through a proxy way of sort of dealing with that if you're interested in studying financial stuff related to Encounter data. There is no Medicare provider number in the Encounter data. I've already talked about that, but there are MPIs. There are more 000 DRGs than in fee-for-service data, but there is a derived DRG provided. But again, shouldn't be used for IP rehab or chart reviews. And a bonus in Encounter records that fee-for-service records don't have is our revenue center from and through dates. Okay, now I just want to kind of give you a taste of the non-institutional Encounter files. There are two of those, the physician or supplier file, which is called the carrier file, and the durable medical equipment file or DME file. The structure of the non-institutional files is kind of the same as institutional, whereas there's a base and a kind of trailer file, or in this case it's called a line file, not a revenue center file. But again, it's header and trailer where there can be multiple lines per base record, and you link them together with those three variables listed here: BennyID, claim type code, and ENC join key. That's the same as for institutional files. If you remember when I talked about the institutional files, there are the lesser used kind of reference files. There are no such reference files for these for the non-institutional files. So the base segment of the non-institutional Encounter files includes a lot of similar information that you'll see in a fee-for-service file. Beneficiary ID, claim dates, facility type, and the name. Let's see here. Facility type, organizational NPI and other provider NPIs, and along with diagnosis codes. The line file, again, has one line per, that shouldn't say revenue center, that's a typo, just I think, more for like HCPC codes. And it will have the BennyID, line number, and line through dates, and HCPC codes. So here we're going to go into some comparisons we made from between fee-for-service and Encounter records, starting with the percent of beneficiaries having any claim or Encounter by file. So on the left is the carrier file, and that will contain your physician claims and some other categories, but mainly physician claims. You can see that Encounter or Medicare Advantage members are slightly more likely to have at least one record in the carrier file as compared to the fee-for-service population, but slightly less likely to have a record in the DME file. But kind of, both are in the same ballpark. And when we look at the overall number of records and lines, do that comparison. On the left is the median number of claims or records per patient. Again, it's quite similar comparing fee-for-service and Encounter. The carrier, there's an average of 19 claims per member for fee-for-service and 18 for Encounter. For DME, it's 3 for both. And when we look at the median number of lines per claim, it's exactly 1 for both carrier and DME for both groups. And here's the median number of diagnoses per record. Again, we have the chart reviews broken out, and it is all very, very similar between the two groups. Encounter Data uses the same procedure coding systems as fee-for-service, which is the CPT, ICD-9, and now ICD-10 codes. ICD-10, I think, came about in, 2015, starting in October 2015. ICD-10 became effective, but so same in both groups. As well as diagnosis codes, it's same for both groups. Okay, so key differences between the non-institutional encounter versus fee-for-service files. Be aware that there is potential for multiple records per encounter, mainly in the form of chart reviews. Coding practices and policies are set by plans, which may cause variation in how care is coded. So Medicare has a billing policy manual with a lot of very explicit detail on how things should be billed, but we do not, MAOs are not beholden to those same policies. So could be that they have their own requirements. So it's just something to be aware of. Another key difference is that there is no payment data. And one last one specific to these non-institutional files is that there is no provider specialty code in the encounter files. So I just want to zero in a little bit on the chart reviews. We'll talk about these a little bit in more detail. So like Steph already talked about, there are chart reviews, and the purpose of these chart reviews is to add or delete diagnoses to a beneficiary's record. And MAOs kind of create these chart reviews as supplements to the encounter records, and they're kind of like after the fact, after the encounter has been submitted, and they'll go back, look through a chart, or and they'll discover a diagnosis that wasn't reported on the initial encounter, and they want to make sure it's on the record, because it will have an impact on how much they're paid for that member from CMS. So they have a strong motivation to include all possible diagnoses for each member, which is what we're getting at in the second bullet here. It impacts a member's risk adjustment score, and that determines the amount paid by CMS to the MAO. So if you want to read more about how, about chart reviews and kind of how they're impacting payments that CMS must give to MAOs, maybe some, question about about that whole sort of system. There are a couple of good citations here that you can go to and read. It's actually pretty interesting stuff, in my opinion. Okay, so we did a little internal kind of research into the 2019 inpatient encounter RIF. And from our calculations, we determined that 20% of members in that RIF received at least one new diagnosis as a result of chart reviews. And it varied greatly by Medicare Advantage company. And there was one in particular that contributed 64% of the cases where diagnoses were added to the members' overall unique list of diagnosis codes. So they contributed 64 of the cases, but while they insure about 26% of all MA members, so they're kind of disproportionate there. The next highest MAO contributed only 7% of these cases. So researchers, so they are adding unique diagnoses, but researchers should consider whether it's necessary to include chart reviews in their analyses. For research projects not affected by diagnosis reviews, service records would be sufficient, and it just would make it does make analysis easier if you can just say, just remove the chart reviews altogether. So it's just something to think about. Here's a table that kind of gives you the percentage of chart reviews by file. You can see that the inpatient file is the one with the highest percentage of chart reviews. This is a very detailed table kind of giving you an accounting of the chart reviews in the 2018 inpatient RIF. We wanted to look at, how many chart reviews linked successfully to a service record, how many did not link successfully. And then we also wanted to look at how many chart reviews added a diagnosis to a service record and how many deleted diagnoses. It's also possible to add a diagnosis to another chart review record. So I don't quite understand, but yes, that is another thing to be aware of. It could be that a chart review is linking to another chart review. So this kind of gives you a nice, I think, sense of how these things all break out. You can see that the vast majority of chart reviews are adding diagnoses, and very, very few are actually deleting them. You can see that over in the far right column, 60% of linked chart reviews are adding diagnosis codes, or actually 60% of, let's see, how do I have this? 60% overall, yeah. Anyway, there's a lot of information in this table. It just kind of give you a sense of what you might expect to see as far as chart reviews go in an inpatient file. It's also possible that a chart review might actually be linking to a service record in a different year, in a different year's RIF. So they have a footnote on the bottom. So that's another possibility. And I think Steph talked about earlier about how some chart reviews don't link to anything. And it's kind of unclear why, what they're there for and why that is. Yeah, something to learn more about, I think. Hopefully as time goes on, that will be come clearer, or things like that will be cleaned up more. We'll see. Okay, so multiple service records for the same service. So just to be I know this is confusing. I'm just talking about chart reviews and how those are, the most common way for there to be multiple records for the same service when you have a chart review and a service record for that service. But it's also just kind of want to touch a little bit on when there are multiple service records for the same service. So removing chart reviews from the discussion for a minute. We can kind of take a look and see, how much duplication there is in a file. And we did this experiment. I think this was on 2018 data using various sets of unique keys. So these combination of variables in the key components column, we kind of use them as unique keys to count duplicates. And so the top one in the first row, that is actually is a 5-key deduplication edit that CMS applies to the data starting in October of 2015. So they apply this key starting in October of that year. So be aware that if you're using data prior to October 2015, you know, there might be more duplicate service records. But if you're working with data afterwards, this edit has been applied. And you know, when we look at this key, we do still find a few. So I'm not quite sure why that is, but it's very teeny tiny, 0.02%. Yeah, we evaluated further using some other keys that were more inclusive. And so, you know, this bottom one here is kind of a way that you might want to deduplicate claims in, say, the inpatient file, because like for fee-for-service, it is possible to have multiple claims for the same inpatient stay in the file. And so you don't want to, you know, if you're just trying to count stays, you will need to either, you know, roll up multiple claims for the same stay into one record or deduplicate. So that bottom set of keys or set of variables is kind of one, you know, way that one might identify duplicate claims for the same inpatient stay. You can see that almost 1%. There's 1% of 1% duplicate service record keys in that bottom category. Okay, so even though it's likely that a very, very small number of apparent duplicate service records occur for like the exact same like service because of the deduplication edit that CMS started applying in 2015. You know, if you want to make it super clean and take a look yourself, it's kind of helpful to know that this claim control number variable will indicate the more recent record. And like in inpatient fee-for-service data, like I said a minute ago, you know, you might want to group one or more unique service records into a single stay. And there's more information, more reading you can do on this topic in Chapter 4 of using Medicare Encounter Data files that you can access on the CCW website. So here's a poll. A good question, hopefully an easy one. What is the most common reason to find multiple records for a single service within a single encounter file? Chart reviews or duplicate service records? That looks like most of you are getting it right. I'd say the answer is chart reviews. Chart reviews are definitely going to be more common than duplicate service records. So, I'm just gonna finish up with kind of some key things that you might want to think about when you're creating your research plan, and specifically for things maybe specific to encounter files. So general rule for all types of files is that if it impacts payment directly or indirectly, its quality will be better than if it doesn't. Let's see here. Rules are common across a year for fee-for-service files, but rules may vary by plan or package for Medicare Advantage. Medicare Advantage plans are not obligated to follow CMS processing guidelines. The structure of Medicare data is complex, and fee-for-service files contain final action claims only. Medicare Advantage files contain final action service records, but they could potentially have multiple records for Encounter due to chart reviews. For both, services provided in different settings will appear in the different research files. And so, example, services using the emergency department visit typically result in at least one facility claim and one physician claim. You'll need to find those in different RIFs. Yes, so consider when data may appear in multiple files to avoid counting duplicate services. And consider when MA beneficiaries may appear in multiple files. For example, the inpatient encounter files include hospitalizations for MA patients. The MedPAR also includes hospitalization stays for MA patients in the form of information-only bills. So you just need to be aware of all this to avoid double counting. When you're deciding how to handle variation in Medicare Advantage, like, are there changes in benefits, reporting, or coding that could impact observed variations or trends? This is just something, to think about when you're using Encounter data. And if something looks odd, this could be some reasons listed here. Could be the reason why. So yes, are there changes in benefits, reporting, or coding that could impact observed variations and trends? Something, here's a list of potential sources of variation or trends that aren't related to actual service utilization changes. They're just more like policy changes or coding changes. And there are 3 key steps to getting started with your research project. First is defining your population of study using variables like enrollment and demographic information. You need to define the events you're interested in, such as like particular treatments or time to a certain event, death or healthcare use, payments. And finally, you want to define some adjusting variables like comorbidities and demographics. You want to make sure that you're, for all of your important concepts, that there are actual variables available in the data to do the job. And if they're not, then maybe readjusting your plan so that you get what you need from the data. Here's a list of additional resources, really good resources. It really does help to dig into these guides to just better understand these very complex data.